Welcome to folks who are joining the webinar. We will give people a moment to connect before we get started. All right, welcome everyone to today's seminar, Lay Health Worker Approaches for Addressing Mental Health Challenges in Populations Affected by HIV in Kenya. This seminar has been co-hosted by the Center for AIDS Research at UAB, the Worcester Hill Center for Health Policy, and the Sparkman Center for Global Health. Some logistical reminders before we get started is please use the Q&A button below to submit any questions you have throughout the webinar, and then we will have time to answer those at the end. And then if you are in the most updated version of Zoom, there should be an option for closed captioning. And now I will let Dr. Janet Turan introduce our speaker.
So welcome everyone. I hope, can you hear me? Yes, okay, great. My name is Janet Turan and I'm the director of the Sparkman Center for Global Health. And I'm delighted to have Dr. Linnet Ongeri here with us today. She is a colleague and a very respected clinician and researcher in Kenya. She works at the Center for Clinical Research in the Kenya Medical Research Institute, or KEMRI, and she has recently completed a fellowship in neuropsychiatric genetics education and research offered by Harvard and the Stanley Center for Psychiatric Research. And so she's really worked in Kenya over many years as a medical doctor and later as a psychiatrist, and has really been an important person in the trying to develop mental health, innovative mental health interventions for people in settings like Kenya. So we're very excited to have her here. I'll mention that she's also involved in policy work. She's a member of the Presidential Mental Health National Task Force and also various technical working groups of the Ministry of Health in Kenya. So I feel that this topic is really important in low resource settings, both globally and in the US. How can we better use lay health workers, people who are not necessarily trained as psychiatrists or psychologists to help promote mental health. So with that, without further ado, I will introduce Dr. Ongeri and look forward to the presentation.
Thank you, Janet. Thank you all. And good morning and good evening to you all. I don't know, here it's more evening than morning. And I'm really delighted to be part of, to be able to present today my experiences when it comes to lay health approaches. So here is let me just share my slide, then we can start off. Thank you for the presentation. I hope, are you able to see the slide?
Yes, we can see.
Okay, so again, thank you so much for giving me this opportunity to present. I'll focus my talk on this lay health work approaches for addressing mental health challenges in especially populations affected by HIV in Kenya. And I will discuss a lot more why should we even be thinking about lay health work approaches in the first place. So touch on the mental health treatment gap, especially in this specific population group. And we'll go through a number of interventions that have been put in just some examples that have been shown to, to be effective, that have been tried out in research in HIV population, among HIV populations. And also I'll narrow in on a case study of one study that we did that especially looked at, that was able to integrate mental health care within HIV clinic, called the MIND study. And then we can go through some challenges and opportunities that are there when it comes to lay health work approaches. So we all know that HIV and mental illness have a very complex and sort of bi-directional relationship. And the reason behind this is because of both conditions have intersecting vulnerabilities. When you look at structural, factors such as poverty, when you look at things like maybe poor housing, things like that affect both, are risk factors to developing mental illnesses, and even risk factors also for HIV. Social vulnerabilities are also there that are shared between these two conditions. For example, the stigma that affects both, conditions, and things like intimate partner violence are, both are experiencing are risk factors for both. And also biological factors are also present for both conditions. So there's that intersecting vulnerabilities that makes it a bidirectional relationship. So people who have mental illnesses, in some instances, may have increased risk of getting HIV, and people with HIV also have increased risk of getting mental illnesses. One of the of course, when you look specifically at the effect of HIV on mental illness, a number of studies have already highlighted the direct effect of HIV virus on the brain through the various inflammatory processes. And also we know the psychological effects of, just living with a chronic illness, the stigma that is involved, having to take medication throughout, that already predisposes one to, a higher risk of developing certain mental illnesses. Now, depression is one of the mental disorders or mental illnesses that have been linked with or are found, especially in people with people living with HIV. It's highly prevalent in this population. It's actually the most prevalent mental illness, and especially now in this population. And aside from depression, the other illnesses that have been seen is anxiety. So these are findings from sub-Saharan studies. For depression, we have rates ranging between prevalence between 14 and 32%, for anxiety between 9 and 34%, for substance use disorders up to 30%, for PTSD between 5 and 20%. And when you compare something like PTSD, maybe in the population, when you look at general population, it's around 3%, so 5 to 20% is incredibly high, especially in these sub-Saharan settings. Bipolar disorders hasn't been studied too much, but a few studies that have shown a prevalence of 6% in populations in sub-Saharan Africa, as in people living with HIV, and psychotic disorders are as high as 6% when you compare to maybe 1% of what you'd expect in a general population. So depression is one of the illnesses that have been studied a lot more than most of the other mental illnesses when it comes to this HIV population. And some of the reasons that researchers found that why is it that depression is most prevalent is some of the things that are found when someone has depression, it's associated with suboptimal treatment outcomes. That is for HIV care in itself. So some of these outcomes are delayed ART, antiretroviral treatment initiation. So if someone has depression, they are highly likely to initiate, take longer to actually initiate or even come in for treatment, for screening. There's also poor adherence, even if they've been diagnosed with HIV, the chances of really sticking to the medication as it's supposed to be taken on a daily basis are reduced when someone has depression, comorbid depression. There's also the lack of viral suppression in some instances because of that inflammatory pathway that happens between depression and HIV. Then there's also more rapid decline in CD4 cell count. through the same pathway and faster progression to AIDS, and that also leads to increased AIDS-related mortality. So again, there's really, a critical need to, focus on mental illnesses with patients who have HIV. So the comorbidity of mental illness should really be critically looked into. So we know that there's a high burden of mental illnesses in this particular population, but sadly enough, there's really a treatment gap. Many of the people who have these illnesses that I've just highlighted are not being, initiated into care. They're not being screened. They're not being treated for the illness, for the mental illnesses. Excuse me. And that a focus still remains on maybe managing the HIV, illness itself, and also providing some very basic psychosocial kind of support. So it doesn't really address the mental disorders that we've just looked at. So some of the factors that contribute to these challenges to identify and treat mental disorders in people living with HIV, especially in sub-Saharan Africa, include we have a mental health workforce shortage. If you look at the graph that is on your right, the figure on your right just shows, this is from the mental health atlas of WHO mental health atlas. Specifically, if you focus on Africa region, we have a very huge, the ratio of between providers, mental health providers, and the population is, it's incredible. It's 0.9 per every 100,000 population. And it means that, as much as we can try and maybe train even more doctors to be psychiatrists, more nurses to be psychiatric nurses, the chances that we'll be able to reach a ratio that actually, is able to cater to the needs of the populations are really slim. Hence the, thinking around, we have to include lay health workers to be able to help at least bridge this treatment gap that we're having. So aside from the mental health workforce shortage, there's also limited time available in the care settings. This is both in HIV clinics and also in primary healthcare settings. Usually these settings have really, really long queues, and the providers say they don't have time maybe to start providing psychological treatments on top of the normal day-to-day kind of care that they usually provide, the treatment as usual that they provide to the patients. Then there is also limited mental health training now for HIV clinicians. Even if they had the time, do they have the skills to provide this kind of care or to address mental health needs in this particular population? The other factors contributing is very few validated and culturally appropriate screening and diagnostic tools. A number of the tools that have been there, at least right now, there's PHQ-9 that has already been integrated, but it's not really something that is used as frequently. But that's just for depression. What about PTSD? What about psychotic disorders, bipolar disorders? None of that. We don't have validated and culturally appropriate, short screening tools that can be used together with all the tools that are being used within the HIV platform. Then the other thing is, of course, competing priorities. Maybe they feel like, the CD4 count, checking viral loads, and also looking at other comorbidities like TB is more critical than looking at mental health issues, based on the fact that this is something that is not, they don't have maybe a physical presentation majority of the time, despite the fact that maybe the depression may still be there. So there's that competing priorities that also reduces the chances of identifying and treating. And lastly is the poor integration of mental health services into HIV care, which is what we are really trying to figure out, what systems, what models would work to be able to integrate mental health services in HIV care, despite all these challenges that I have mentioned. So to improve outcomes, as I've mentioned before, we really need to prioritize on implementation research that is able to look at outcome effectiveness outcomes, and also look at acceptability. Is it acceptable based on maybe the culture of that particular setting? Are the models or the interventions that we are putting in to integrate mental health services in HIV care, are they effective, and are they acceptable? Some of these models include the task shifting and task sharing, task shifting is now what we're pushing, like really referring to with the lay approaches. And then also there's a need to consider priority populations living with HIV, especially because these populations are even more vulnerable when they have this comorbidity of HIV and mental illness. The populations are like children and adolescents, pregnant and postpartum women, and also other key populations like sex workers and like men who have sex with men, transgender people, persons. Those we need to consider those are priority populations, and some mental integration needs to even focus a lot more within this population group, priority group. Some examples, I'll go through a few examples of lay approaches that have been they're already going on in Africa and also in Kenya. One of the approaches that has been put forward is the integration of the mental health gap, the MH gap. And in the studies that have already been conducted in settings that have high HIV population, they're showing that there's increased identification, treatment, and referral for mental health disorders with the use of MH gap. The MH gap is a WHO tool that looked at, it was published in 2008 and updated just recently in 2015. And it provides evidence-based guidelines on how to diagnose and manage common mental disorders and manage, and it can be put in the community settings and also in primary healthcare settings. So I'm just on the right, there's a paper there about contextualizing, because the WHO urges us to, once we have the MH gap, we have to contextualize it and adopt it to the population group that we are using it for. So we have undertaken some work in Kilifi, that is at the coast of Kenya, to contextualize it. And right now there's someone, Mary Bitter, she's doing some work to be able to actually, she's training frontline workers. This is mostly frontline workers, so not psychiatrists, so non-specialist training on using MH gap to be able to identify and treat. So this is not specifically in the HIV setting, but HIV rates in that particular region are pretty high. It's more of a primary care setting. Although there's a colleague of mine who's also doing a similar work in Eldoret, and this is actually in an HIV population. So MH gap is one of the models that are being used, and it can be at the facility level, it can be at the community level, all at primary care level. The other models that have been looked into is the task shifting and task sharing. And in this case, we've seen a number of studies in Zimbabwe. We'll talk a little bit about these models that have been used, for example, in Zimbabwe, in South Africa, even here in Kenya, in Uganda, on non-specialists, how non-specialists can provide effective screening, evaluation, and treatment intervention, both pharmacological and psychological. Pharmacological, usually it's by nurses who are trained to provide antidepressants, for example, for depression, for patients with depressions in HIV clinics. And there's also, but one of the key things here is we emphasize, whenever we are thinking of task shifting, task sharing, we emphasize on looking through appropriate training, supervision, and mentorship, so that the modality can actually be sustained and scaled up. So among the psychological interventions, I thought I would highlight this, some of the psychological interventions that are being undertaken by lay health workers. One is problem-solving therapy. For example, the friendship bench. I'm sure a number of you are, you've heard of the friendship bench. It was started by Chibanda, Dixon Chibanda, and in Zimbabwe. And he uses grandmothers to be able to provide some form of problem solving and sort of CBT, shortened CBT kind of therapy to address depression among people attending primary health care. So in this particular friendship bench, I mean, a lot of the population has a high rate of high prevalence of HIV also. So it's thought that it can also actually work within the settings of HIV, people living with HIV. The another problem-solving kind of therapy, which is also a mix of problem-solving and CBT as well, is something we call PM+. PM Plus is a therapy that has been it was developed by WHO. And in Kenya, we've used it in a number of settings. It was actually tried out in about 4 different counties in Kenya. And what the therapists do, and it was, in fact, the figure on your right shows it. First, the trainers from WHO and World Vision came in and trained Ministry of Health staff. So that is at the national level. And these were are the master trainers that are named the master trainers. And then the master trainers went out to the various districts. There were about 4 counties that were identified, 4 large counties interspersed within the country. And they trained Ministry of Health staff within primary healthcare settings to be able to provide, to be able to train on PM Plus. So this district level Ministry of Health staff became the PM Plus trainers and supervisors. Then now these trainers and supervisors went down to the grassroots and trained community health volunteers on how to provide now PM Plus. And these are the PM Plus helpers. So this is a therapy that lasts, that takes 5 sessions. It lasts 90 minutes. It's primarily targeting, it primarily targets people with psychological distress. So it's not a diagnostic focused kind of therapy, because it just looks at psychological distress in general. And it trains the community health volunteers at which point to refer for specialized care. It's worked very well. I think they're even now within a phase whereby they're now using it to address intimate partner violence, and it's being used for males who are using substances, abusing substances in some part of it in central Kenya. So they've scaled it up. They're looking at other settings, not just in general. Now looking at aside from just psychological distress, they're looking at substance use and if it can be able to reduce violence among these thought to be perpetrators. So aside from problem-solving therapy, there's also group interpersonal psychotherapy. Group interpersonal psychotherapy, it's been recommended by the WHO, and there's actually a manual on how to go about using group interpersonal psychotherapy. In Kenya, we've had a number of scientists or researchers who have put in these interventions, but one that is specific to people living with HIV is one that is currently ongoing. I think they're in the process of completing data collection for this intervention. They had about 20 adolescent mothers who are HIV positive, and within sort of informal settlement, a slum kind of or low resource setting here in Nairobi, so an urban low resource setting, and they recruited adolescent mothers within the intervention, and they were providing group interpersonal psychotherapy for them. I think there's already a process paper on it, but they're working on the final paper to see the findings for this. Group interpersonal psychotherapy in this case was addressing depression, and interpersonal psychotherapy is diagnostic focused, unlike the PM Plus and the friendship bench. Then there's also individual interpersonal psychotherapy. This is where now I'll focus, because a lot of my time has been and experience has been around individual interpersonal psychotherapy with the mind study. And I'll tell you a little bit more about that and how we've scaled it up from the mind study. We moved it to now what we are currently undertaking called the Smart Upper study. So the mind study was in a HIV care clinic, and we needed to scale it up to a primary healthcare setting to see if these same findings would apply in a primary care setting. And so that's ongoing currently. The Smart Upper study is ongoing currently. So a little bit more about the mind study and how we went about it, and how we went about training non-specialists to provide interpersonal psychotherapy. So the mind study stands for the Mental Health, HIV and Domestic Violence Study. And the long title of it is Scalable Evidence-Based Mental Health Care Delivered in Health Centers for HIV Positive Women Affected by Gender-Based Violence in Kisumu, Kenya. So the rationale around why GBV, why women, why HIV positive, specifically is because we know HIV is associated with gender-based violence against women worldwide. And we know persons with gender-based violence have a high risk of both PTSD and depression, both of them. So 60 to 90% of patients with who've experienced GBV also have PTSD, and 50% depression, screen for depression. And both depression and PTSD have been, excuse me, associated with decreased antiretroviral adherence and also detectable viral loads and attrition from HIV care. So in the US and also in many high-income countries, there are already treatments for depression and PTSD, psychological treatments for this, and that have been shown to work. And actually, by the time they are being used, they reduce ARV adherence and decrease also in HIV viral load. And not just in the US, even in sub-Saharan Africa right now, there's a lot more studies that are showing treatments can help in reducing, in increasing adherence and reducing HIV viral load. So we know that 75% of HIV positive women live in sub-Saharan Africa, and gender-based violence is very prevalent. And at that point, when we were doing this study, there was really no treatment that was focused for this specific group, HIV positive with gender-based violence with both PTSD and depression. So prior to undertaking our interventions, our IPT, our interpersonal psychotherapy intervention, we did a formative phase of the study whereby we had qualitative questions, and we were exploring from the women themselves various things around the violence against HIV positive, what really happens when a woman is HIV positive, what kind of violence happens, how does it come about? And indeed, the women did report that, yes, they experience intimate partner violence, they experience violence from in-laws, from co-wives as well. And I mean, they give a lot of quotes that, you know, a woman tends to be victimized and blamed for the infection. And that in itself keeps that blaming and victimization increases, you know, the risk of violence, both emotional, sexual, and physical. And they did also say that they do go through a lot of emotional challenges, especially depression. They talked about stress, they talked about poor appetite, shame, and also memory difficulties. And they felt segregated and despised. You just feel hollow. That's some of the quotes that we got from that. And they did say, yes, it does have a direct effect, because when someone loses their appetite, they don't feel like they can be able to take their ARVs as they're supposed to do. And also the memory challenges, they forget when they're feeling low, when they're feeling depressed, the memory is affected, they forget to take their ARVs as recommended. Then we asked them also, how do they cope with these emotional challenges they are going through on a day-to-day? And they say they have women's group, something we call Chama locally. And they say they come together, they talk, they survive by encouraging each other. So we asked them if they felt like there's a need for mental health care, and they said yes. And so we asked around preferences for this mental health care, and they were really adamant about having it within a clinic setting rather than household, again, based on the stigma that is already attached to both conditions. And they preferred it individual. Again, it was more leaning back on the stigma aspect. They felt like they can be more, these aspects of privacy, they can be able to share a lot more in individual sessions. And they said they were okay with the weekly session. So this actually advised our selection of the intervention. So IPT, for this specific study, maybe I'll talk a little bit about IPT. It's a time-limited diagnosis-focused psychotherapy. We usually give 10 to 12 sessions, and an individual, a client comes once a week for 10 to 12 sessions. The research has shown it's effective for depression, and even RCTs that have been done for IPT in HIV populations have been shown that it's just as effective. And also it's non-inferior to traditional exposure methods. When you compare it to traditional exposure methods and IPT, it's just as, it's non-inferior when it comes to managing PTSD. So we thought IPT made a lot of sense as an intervention in this particular setting. So for our specific intervention, we did more of a hybrid design, type 1 hybrid design, whereby we were looking at both effectiveness and also implementation goals. And the first thing that we looked at, we enrolled women who had both HIV and gender-based violence, and we randomized within the Faces is a HIV care clinic, and we randomized them between people who were getting, sorry, just a second, people who are getting IPT and treatment. One group got IPT and treatment as usual, and then the other one got, after 12 weeks, they managed to get, for the 12 weeks, they were going through treatment as usual. And then they got, after 12 weeks, they started also on the IPT and treatment as usual. So the treatment as usual here is just psychosocial kind of support that they usually provide in the HIV clinic. So both groups are getting that, but one group started out with the IPT, that is diagnosis focused. So at baseline, we took several measures, and we followed them at 12 weeks point, 24 weeks, and even at 36 week point. I think my slides have, let me see if I can make them move again. Yeah. So maybe one of the things that, so specifically focused on the IPT therapist, how did we go about selecting this in this lay approach? How did we select the therapist or the lay staff who are able to provide IPT treatment? So first of all, excuse me, we did recruit from the, we did a link with the Faces. That's where we recruited this therapist from. The therapist had to be all women based on the, the fact that we're looking at gender-based violence. We thought it might be a bit triggering for women to have male therapists. So we had women therapists. And the level of education, they just had to have completed high school and to be able to communicate at least in the local languages, either Luya, Luo, and the English. I mean, it's a standard if they've completed high school. The other thing, when we're doing the recruitment and getting to know the participants, what we're looking for was mostly that empathy and the passion and the interest in mental health. And that was really what was guiding us, rather than have they done, counseling work before? Do they have, background in counseling or mental health? It was really more just having an interest and having that empathy, even within the interviews. So the training, we did training for 10 days. And we had to, prior to training them on, the modalities, we had the manual, and we did an adaptation of the manual prior. And even during the training, we did more adaptation of the manual, the IPT manual. So after that, we did supervision of practice cases. So each of the therapists had a practice case, and we would call them on a weekly basis and follow up on each and every week what happened with the practice case. And then we would score them. We did a telephone supervision for that, and we would score them on a Likert scale for 1 until 10, and they had to score at least 9 for them to be able to qualify now to get a participant. And we followed up adherence. We were looking at are they able to maintain that fidelity of this particular therapy from the initial formulation, the middle, until the termination phase. The other thing, we looked at the trainer. We also trained some of the therapists, the ones who were very promising and who had a little background in some mental health. Maybe they had been counselors before. We asked them to be trainers of the trainer. So we had the supervision, the weekly supervision on telephone, and we also had the trainers be able to lead peer support groups for the therapist. And this was really important, both to help in debriefing, because GBV, HIV, PTSD, depression, all those are very, very heavy kind of areas. And the therapist needed a space where they could also debrief and be able to cope, have ways of coping themselves, so that they can provide therapy to the participants. Aside from that, they were also looking at the fidelity of the IPT itself during these peer meetings, peer supervised meetings. So specifically for the MIND study, we were looking at various outcomes. So it was hybrid. So we were looking both at clinical and implementation outcomes. For mental health, we looked primarily, primary outcomes were depression and PTSD, diagnosis of the PTSD and diagnosis of depression. Our secondary outcomes were symptoms of depression, symptoms of PTSD, looked at intimate partner violence. We looked at social support. As well, we did neurocognition also within this MIND study, where we were looking at executive functioning, speed, learning, memory as well. And we looked at parameters from medication adherence and HIV viral load. We took viral load baseline and at 12 and at 36 weeks. And we also looked at disability and quality of life. Excuse me. And for the implementation, we did qualitative interviews towards the end to just talk to the therapists themselves. We looked at adherence on the treatment protocol as well. We measured adherence to treatment protocol. And also we talked to a number of stakeholders to be able to engage them, let them know what we are doing, find out how scalable our particular model can be, what we need to put in place for us to be thinking in terms of scaling it to county and even a national level. We also looked at the economics of it, so microcosting of the study. For the feasibility aspects, I've already mentioned that we did this IPT therapist trainings, and some of the outcomes, we had to train a lot more therapists. So we started out with 21 therapists joining, and out of that, 10 of them managed to successfully complete with the practice session. And by successfully complete, meaning they were able to score the 9 or higher during those fidelity, during the assessments. Are they able to stick to the different phases? Are they able to meet the fidelity of the therapy? Then when it comes to the participants themselves, the study participants, we had an overall non-completer analysis of 35% of the participants did not complete the entire trial. And this is even, we're talking about not just the 12 weeks, but even the 4 times. It includes the 4 assessment points. So pretty high, which is 35%, 90 out of the 2. And we had a total of 256 participants joining the study. So 90 out of the 256. And I'll discuss a little bit more about this in the challenges of this lay health work approaches, especially the IPT. And but it has a lot more to do with not necessarily the therapy itself, but the mobility of people who live in these regions. Everyone, a lot of the time we find people moving from one area to another, maybe based on the vulnerabilities we had talked about. Maybe they are having hardships with housing, poverty issues. They want to go and stay somewhere else because of work and things like that. Very high mobility contributed to this non-completer analysis. And we were looking at it for even the 4 assessment points and not just the therapy itself. But when you look, when we looked at the effectiveness outcomes, specifically the first graph looks at major depressive disorder group. We were able to see with the IPT, that the group that started with the IPT and treatment as usual, there was significant reduction in major depressive disorder at a p-value of 0.002. And this was the same for PTSD group. When we measured at 3 months after the therapy, this was a p-value of 0.02. And when you combined by both conditions, MDD and PTSD, when we look at both conditions, it's still the significant, where the IPT group, the one that started out with the IPT, still had significantly reduced symptoms of, not symptoms, but actually the diagnosis of depression and PTSD at p-value of 0.03. So at the conclusion of treatment, those who received IPT had significant reduction in both MDD and PTSD, and also combined, compared to the wait list and the treatment as usual, the control group, which was a wait list. And The waitlist also experienced similar remission after they received the IPT treatment, and the gains were maintained, across the various follow-ups. The secondary findings from our study showed compared with controls, IPT participants had a greater reduction of disability, intimate partner violence as well. And though it was insignificant, they had also had reduced work absenteeism. So one of the things maybe I should highlight is in the graphs, there is also, we see the group, both the group that was on the wait list, the control group, and the ones that received the intervention group, both had, still depression and PTSD still going down. And this is thought, and it's been shown in a number of other similar studies, that just being able to ask participants on their symptoms, like, have you been experiencing this? Have you been experiencing that? Just having someone there to, ask you about your mental well-being in the first place does have some effects in terms of reducing this symptomatology, whether depression and or PTSD, and that can be seen as because the graph goes down for both groups, and that's really thought to be the effect of that, because a lot of these patients or participants are not given the platform or even a space to be, asked in detail with someone who's empathetic on what they've been experiencing. So that in itself has some effect, positive effect. So in conclusion, delivering IPT to HIV positive women affected by gender-based violence using clinic integrated non-specialists can achieve substantial remission of MDD and PTSD, and this was sustained over a 6-month follow-up period. And also there were apparent reductions in disability and physical violence by intimate violence, just being able to manage depression. Because within the IPT, we teach them a number of skills. Some of them have to do with communication, assertiveness. All these things have a bearing even when it comes to intimate partner violence and how they're able to communicate in certain settings. So we published our paper in the PLOS Medicine. It's there, and those are my, the co-authors, collaborators. Susan Meffert was a PI for this particular study and is the PI for the SMART DAPA that I just mentioned we are conducting. The SMART DAPA specifically is looking at 2 arms. It has a SMART arm of the study, but the first randomization looks at, compares fluoxetine to IPT. So there's an arm for fluoxetine and an arm for IPT. In this case, it's in a primary healthcare settings, and we are recruiting both male and females. It's not just only females. And the other thing is that it's all primary care patients, so whether one is HIV positive or not. Although with the high prevalence of HIV in Kisumu area, I think about 60% of the participants are HIV positive. So we're trying to see how that works. And we have a SMART aspect of the study whereby if the symptoms do not resolve, then if the disorder does not resolve, then they're able to be re-randomized again and get the other or a combination of both. That's for the SMART DAPA study. Still, we're using non-specialist nurses. Trained nurses are providing antidepressants and for the fluoxetine arm, and therapists or IPT therapists. These are people who've just achieved high school level of education. They have empathy. Some of them might have counseling background, but they're not necessarily specialists, are providing the IPT therapy arm of the study. So some challenges and opportunities, this is in general, both from experiences of PM+ and also experiences from IPT. Some of the challenges that we saw, especially in the MIND study, was this high rates of mobility in the community. So based on the fact that IPT, for example, needs 12 sessions and PM+ needs 5 sessions. So it needs someone to keep coming for the session for it to work, and also more or less stick to the 1 week time. We could still have some leeway, but ideally every week to come in for therapy. So of course, if there is a population that is moving around a lot more, then the attrition rate then becomes a bit of an issue. We could think of many other ways of going about it, of mitigating this. For example, telepsychiatry, to be able to provide therapy virtually, and this is an arm that we're also testing in the SMART DAPA study. The other thing is supervision of therapists. It can get very exhausting because for the IPT, we did not do so much of training of trainers. For the SMART DAPA, now we've done a lot more of that. But for the MIND study, we just, myself and Professor Susan Meffert were the ones who were doing the supervision. So it can get very heavy being able to supervise all these therapists. And but also, for sustainability, you have to think of, even as the study lives and you continue and you scale it up, who is going to be doing the supervision. So the aspect of training, Ministry of Health, training even psychiatrists and psychologists to provide these therapies is very important, because they probably be the master trainers, they'll be the ones doing the supervision. So it's important to think through the supervision process because you can't have any lay approach without a solid supervision put in. Then also where to cite it. Some of these lay approaches, we went back and forth. Many people are saying, why don't you cite it in the community versus citing it in a facility? But you see, an integration for mental health care services can be different, can be at the community and the households, and it can be at the primary health care facility as well. So this really depends on, on various factors. But I think for diagnostic, if you're just looking at people who already have depression, because that's already an illness, it's important to consider maybe facility-based as opposed to at the household level. But if it's psychological distress, I think that's it's okay. And both have pros and cons, as I've mentioned. Yeah. The other thing is a few specialists are trained in IPT, even as much as we think IPT works really well in our setting, because we already have these ways of dealing with stress. We come in groups, we support each other from an interpersonal basis. There are very few people who are trained in IPT, and this includes even the psychologists. So we have to think of ways of training more and more people to be able to provide care, especially the ones that we think will be the supervisors. The positives or the opportunities we have is the less stigma with therapy and counseling. This is something we've especially seen in our SMART DAPA study. Most of the participants, when they are, a lot, not most, but a number of participants, when they are randomized to the arm of fluoxetine, will say, no, I only joined the study because I wanted to go to counseling. So they refuse to continue with the study because they've been randomized to the medication because of the high stigma that is involved with medication. People think that if you're on antipsychotics or antidepressants and you're seriously mentally ill, and there's heavy stigma with mental illness. So the putting lay approaches that especially focus on counseling or therapy, psychotherapy techniques is a plus, because it will be embraced a lot more by the community. The other things are effects tend to last longer. We measured, participants even way after at the 36 week, at 6 months. So because they're taught coping skills, and they're taught coping skills, these skills go with them even post the therapy sessions. So the effects tend to last longer. Even from other studies have shown the same. The other thing is issues around drug stockouts. When you're comparing it with pharmacological treatments, there's lots of drug stockouts that we're even experiencing with our SMART DAPA study. So if it's therapy, it's available, the person is there to provide the care, then at least we don't have interrupted kind of treatments. When the other issues around, the other opportunity is also that we have enough lay human resource available who are willing to be trained, who are willing to provide care to our population. So it's something to think about in terms of, including that. So these are some of my references, and I think I'll conclude there. Again, thank you so much for listening. Any questions are welcome. Thank you. Stop sharing.
Thank you very much, Dr. Ongeri. That was a great presentation and really comprehensive. And I have so many questions, and maybe I'll have to save my questions for later. But I don't know. So in the chat, I see there's a question from Alison Spenceley, who is one of our colleagues at UAB, and she says she wonders how the Ministry of Health is responding to these findings. Are there any discussions or interest in rolling out this program out or scaling it up? And probably referring to the IPT, I guess. Mm-hmm.
Yeah. So yes, we especially for the SMART DAPA, that's how we were able to now scale it from the MIND study into the SMART DAPA study. And we've actually included the Ministry of Health. They are consultants in the SMART DAPA study. We've been talking to the county officials as well, telling them about our findings from the MIND study and also what we're seeing with the SMART DAPA preliminary findings from the SMART DAPA study. So we are working hand in hand with both the national and the county government to see how best to scale it up. We have developed a manual that has been adapted specifically, for this kind of work. And we are also in discussions with various training schools, for example, KMTC, the Kenya Medical Training College, that provides training for nurses and clinical officers. We are in discussions with them to see if we can integrate this manual within their training so that when they come, they have some skills in IPT. And we are also providing, we have this SMART DAPA also includes people, officials in Uganda as well. So we've already started providing trainings for the psychiatrists in Uganda. We plan to have a training session for psychiatrists in Kenya because we realize we cannot just train lay health workers on IPT and fail to train the people who will be supervising or master trainers supervising them. So we are training, trying to focus on this specialist for them to understand what IPT is all about and for them to be able to be, confident in also supervising in the event that they might need to supervise other lay health workers in providing this treatment. Yeah. So we are in discussion and it's a very important, that's why it's even more implementation than anything. The SMART DAPA is more implementation based. Yeah, thank you. Thank you for the question.
Oh, thank you. And I encourage anybody who has further questions to submit in the Q&A or the chat. I have one question around for people who don't know on the call, there's a short screening instrument for depression that is used in a lot of research studies called the Patient Health Questionnaire, and it has different versions of 9 items or 8 items or 2 items. And I was just wondering what evidence or what information you are aware of about the cultural appropriateness, acceptability, understanding of these depression items in Kenya.
Yeah, I think I'll maybe answer it. There's no really short answer to that. I know there's been a number of maybe 2 or 3 studies that have validated the PHQ-9 within our settings. One, I think, even in Western Kenya. So, but still whenever from practice, as in I see when people actually using the tool, they say they're not capturing enough depression. They feel like they're missing depression cases, that it's very low rates prevalence of depression. So they're wondering, is this really measuring depression accurately? And I think maybe a lot of the things may be related to translation issues as well, because there's maybe one version was validated the way it was translated, but maybe you want to translate it into Dholuo, the local language, into another language, Kiswahili, but use it maybe, and then the Kiswahili also changes. You see, the way we speak Kiswahili, maybe in Nairobi is very different how they will speak it. Western Kenya, how they will speak it in a different place. So maybe it's a lot more expensive, but being able to do a short validation study prior to doing an intervention or screening may help. But I know there are challenges with these screening tools, but I think a lot of them stem from more of even translation issues rather than even the construct. Is the construct being asked, really picking depression? Yeah, that's what I can say about it. Yeah.
Thank you. Yeah, I realize it's a long topic, but
yes,
thank
yes,
you.
it is.
Thank you for that. Okay, let's see. I'm waiting to see if there are any others, but I will throw in another question. Okay, a lot of the work that you've mentioned is about depression. So what can we do about the other mental health disorders that are, also you showed they had relatively high prevalence, some of them. Is there any, can we still use lay health workers to a certain extent, or what are your thoughts on that?
Yeah, I think, okay, especially for Mind study, we looked at both PTSD and depression. So the participants had both. And even for this SMART DAPA, it's both PTSD and depression. But I think specifically looking at, disorder specific, I think the MH gap looks at various disorders. So depression is included, doesn't have anxiety, but it has trauma-related disorders. It has a number of disorders, and how the MH gap is structured is more for, you train the community health workers to be able to identify, using the MH gap tool, to be able to identify these illnesses and be able to refer patients from the community to the facilities. And then you train the frontline healthcare workers, so usually just nurses or clinical officers, to be able to manage these conditions. So it's more like two-front, whereby you don't now need a psychiatrist or a psychiatric nurse to come in and manage all the cases of depression or PTSD or bipolar disorder and all those other, mental health conditions. So you have a number of, you have a larger pool being able to manage the condition. That's the frontline healthcare workers. And you have a pool of lay health workers also, or lay people who are able to identify, go into the community, identify people with these illnesses using the MH gap and link them to care. So we do have that approach, and it's been working. A number of people are using the MH gap. And the PM also is important because, at least for psychological distress, is non-specific to specific disorders, but anyone who's having psychological distress can be able to be reached and care, at least that basic level of care provided for such persons in the community. Yeah, and it's also it's based in the community. There's not much linkage with the facility. So that of course has its also positives, the fact that it's based in the community. Yeah.
Okay, great. That's very helpful. And I see a question from Lisa Kimbo, who is one of our doctoral students in our department, and she's from Kenya. And she's saying, could you tell us more about the link between GBV and use of healthcare services in Kenya?
The link?
I guess,
okay.
Like, how does women who have GBV, how does that affect their healthcare service utilization?
Yeah. I think, although even that is a heavy question, it has very many paradigms, but just on an overview, I think I would say that GBV itself, you see the mental status of the person who's undergoing through a lot of violence, it puts them in a state whereby it's difficult to seek help. It's difficult to open up because of the stigma of GBV itself, because they're going through a lot of stress at that particular time, and also because of fear. There's stigma, there's fear that the perpetrator might find out and this might happen. So of course, the care seeking is reduced. And there's also the psychological play that comes in when for GBV, people going through gender-based violence, there's psychological burden that they have to deal with of, first of all, just revealing that they have a partner or they're going through this kind of thing, but also they believe that maybe the perpetrator did it. It may be a one-time thing, it happened just like that, and things will get better and things will get better. So there's that psychological aspect that it takes actually a lot of social support for the victim to be able to get to care, to come into care and be taken care of and be helped in, on the long term. I think if the person feels like there's someone else they can rely on, there's someone else they can lean on, then there's a higher chance of them getting linked and also continuing with that care, and also leaving the perpetrator if need be to be able to heal from that kind of relationship. Yeah, I don't know if I've answered the question, but yeah, I hope I have.
I think you've done a nice job, and it's a complicated question. So I guess I think our time is up. So it went by very quickly, it seems like, but we just want to thank you so much for sharing this, and we will be sharing it with our wider community. And I hope we can reach out to you if we have questions or would like to collaborate or things like that. So we look forward to continuing collaboration on this really important topic.
All right. Thank you so much for the opportunity. It was wonderful coming to the meeting and also being able to present. And if there are questions, any interest in collaboration, I'm very open to that. So thank you so much.
Thank you.
Yeah.